Welcome. I'm Dr. Leonard Calabrese from the R.J. Fasenmyer Center for Clinical Immunology here at the Cleveland Clinic. I want to welcome you back to this roundtable in our program called TB Testing in the 21st Century. We have 4 outstanding webcasts that have broken down this problem of tuberculosis in the time of biologic era. So I encourage you all to come back to see these individual presentations, and you've already met my faculty. So I have my good friends here, Jack Cush, Kevin Winthrop, Arthur Kavanaugh, Xavier Marriette, and I'm going to show you a real-life case. And we're going to kind of get the opinions of these experts, as they say, on how they'd handle this. So this woman comes into a rheumatologist's office, any office. She's 45. She's from Peru. She has active rheumatoid. She's CCP positive. She's on 17.5 of methotrexate and 15 of prednisone. Her disease is still very active. She said she can't take any more of these medicines. She's heard about other options and biologics. She watches TV, and she said, am I a candidate for this? And, I think she sounds like a pretty good candidate. So the rest of her history and physical, aside from the arthritis and her active joints, is pretty unremarkable. She's already had some screening tests for hepatitis B and C. They're negative. And it comes time to think about screening for TB, and she says, I have not had this test done recently because I've had this test done in the past, and they said it's kind of slightly abnormal, and I come from Peru, and I've had BCG, and they told me that I really shouldn't have this test anymore. So for you, watching in right now, what's the next logical step? What do you think? One, should you assume, based on her history, that she has a PPD that's positive from BCG and thus start a TNF inhibitor? On the other hand, would you disregard this and just repeat this PPD regardless of her history? Another option would be to assume that she does have a positive test and to treat her as latent tuberculosis and then get the show on the road to start a biologic. Or, as we have discussed in our previous webcast, would an IGRA test be to her advantage in sorting this out? Or do you have another opinion? And there's room for lots of thinking. So the first thing, I think I want to turn to Kevin, because you're the TB guy and you do this for a living. So when a person comes in the office and says, I'm from Peru, or I'm from Chile, or I'm from Uzbekistan, I mean, what do you do to assess clinically the risk of TB?
Sure. Well, obviously the epidemiologic history is key, Len. And someone from Peru, I mean, it's a coin flip. It's probably 50% chance that they have been exposed to TB. I mean, we have skin test studies at least from many years from that area and other areas in the world, and it's probably somewhere 50% or higher. So, again, some of that may be due to interaction with BCG, and we don't know what the true prevalence is. But I would not be surprised if it's a coin flip.
So you'd say part of the history, routine history, in a practice where you're using biologics is to find out where these people are from. What other factors?
Sure, absolutely. So a priori risk is really the number one, and where they're from is the main component of that. Other factors, taking a close history about prior testing, which you did with this patient, and she was able to tell you she had some sort of test before. And a lot of times those histories aren't reliable. You don't know whether the skin test was really positive, was it placed right or read right. But again, that's important, finding out about their prior testing history and treatment history.
Anybody else have a pearl in this setting?
Asking about recent contacts, but I mean, she has a lot of the components we worry about. She's on high-dose steroids, 15 milligrams. She's about to go on a biologic. She has a disease that may put her at additional risk itself. So that, along with where she's from, testing and screening is going to be very important, because we need to know whether or not she needs to be prophylaxed if she's going to get a biologic.
I would focus on the steroids as well, and as you're moving to a newer therapy, certainly try to get that down. One other aspect of the history I like is that she's a non-smoker, and I think there's some data that suggests that TB can be more prevalent and more serious among smokers. I think that's actually a nice bit of the history that's relevant, of course relevant to the RA as well.
All right, so everybody's got in their mind what you may want to do and what you may not want to do. But let me just tell you how the case actually goes. So this physician in this office said, I think I should do that PPD again, because that's not a very reliable history I just got. And he prepares to give her this PPD, intradermal test, and says, I want you to come back in 48, 72 hours to have this read. She goes, you know, I'm sorry, I live pretty far from here, and I can't come back. And, you know, I'm a pretty smart person. I can read this myself. I'll do anything you want. I'll draw on it. I'll take a picture of it. Is that acceptable today? I mean, that sounds like a pretty good plan to me for somebody who knows what they're doing.
If there's an app for that.
Yeah.
No. Seriously, though, I think this actually could treat it like much of medical data. I think you deal with the sensitivity and specificity. If it was positive and you got a picture of that, I think you would be convinced it was positive, perhaps, depending on how it looked. Trouble is if it's negative, and I think that's what you really want to know. So I don't think that would be acceptable.
I don't think you can feel induration with the iPhone. I mean, that's not yet. There might be an app coming, but yeah, that's the problem, right? I mean, you could see it, and oftentimes the erythema correlates with the induration, but it really, the money is in the induration. You have to be able to measure the induration, and we don't know that erythema correlates with disease. It's really induration. So you'd really need her to probably show you, I mean, if you did this, she would need to show you how she's measuring induration. But I wouldn't do this. I think this would be not optimal. So
I'm getting a sense here that self-reading is not a reliable technique, and you would prefer to have this patient read by a healthcare professional that knows how to do this.
I prefer to have it read by the person who administered. The best test is the one that's done by you, read by you. When you send it to another healthcare worker, that is certainly acceptable, but there are problems with their training and their interpretation, and equally problematic is the reporting back to you and adequate documentation. So there are a lot of places where patients can fall through the cracks, and you may not actually find out the right result.
Yeah, I think by definition, an induration is palpable. It is absolutely mandatory that this woman see a healthcare professional for saying it is an induration or it is not an induration. Yeah. And iPhone cannot do that.
Okay. Yeah. So, story unfolds a bit. She does return to the office, and the patient care assistant who did this test comes out and says, I measured this induration at 6 millimeters. And you go in the office and you say, I don't think it's 6 millimeters. I think it's maybe 5 millimeters, or maybe somewhere around there. I mean, this is not an uncommon scenario. And, you know, just do the math and see what 5 millimeters and 6 millimeters actually is. And it's, I think it underscores much of what you said in your presentation, Jack, about reproducibility and accuracy. So this would be technically a possibly positive test. There's this history of BCG. What would you do in real life now? This is TB, let's treat it, or are we still wondering here?
Well, with the history of BCG as it was before, I would not have done the skin test, and for two reasons. One is that this scenario, where I'm not sure what to do with the result and I still want to know, so I would probably perform an IGRA. And the other reason, though, is that if it was positive before, she could have had a bad reaction to the second PPD. That certainly does happen with skin sloughing and other problems, and continuing to challenge people who really do have TB. You don't want to do the PPD over and over.
Well, I agree with Artie. I probably would have gone with an IGRA just because of the BCG history, and that would be within the recommendation from CDC and other agencies or guideline groups. But you didn't do that. Now you've gone down this path, and so you're boxed in, and you have to decide what to do with this. I like to treat TB, so I would probably treat her. That's what I do. But she's from Peru, and she's got evidence of probably a good probability, a baseline of 50% of being infected. This is probably enough for me to go ahead and offer her a therapy for LTBI.
Really?
She is a high-risk person, and she has a positive test. You know, a positive IGRA or positive TSD is reason enough to receive therapy. And what you can't do is you can't use one test versus another to get a reason to not treat patients. If you do the test, you have to respond to the test.
Because there is no gold standard for
That's
this.
true.
And that's the problem.
And remember, she's on 15 milligrams of prednisone. She's on these things that may make her skin test not react the way it should.
Xavier, how would this patient be handled in your center?
As RT, I wouldn't have been down TST because of the two reasons he gave, and I would have done IGRA. But maybe the question, as Kevin said, the risk of TB, of latent TB, is so high in these patients of Peru. Is it necessary to do a test, or may we treat latent TB because we want to introduce anti-TNF without any supplementary test, just on the history?
That's
Okay, well, we've solved this problem so far, so let's take it to the next step. So actually, IGRA testing lies in this patient's future. So send it to the lab, and you order this test, and sometimes the physician knows exactly what they're ordering. Sometimes they don't know exactly what they're ordering. But there's a gamma interferon release assay available. Your lab sends out the test, and you get this little slip of paper back. It says negative. So we all feel pretty good now?
These are most of my referrals.
That's called when the whole world's a hammer, when all you have is a hammer, the whole world's a nail. Yeah. So
This is the rheumatologist would be analogous to a positive ANA without a titer, without other information. Right. So you need more. It can't be just positive or negative.
I think,
and you can say the same thing about the TST too. It's the strength of positivity, it's the circumstance. Sure. So here you need more information.
Yes, I mean, that's the point that I wanted to bring out in this case. That just as we have become nuanced in our interpretation of ANAs and ANCAs, and an IGRA test is not just positive or negative. There are data to be had. So. This test, here's some data here. So I haven't shown these to these gentlemen before, but there's two tests, quantiferon gold and the T-spot. They're both highly valid and approved tests. And there's a bunch of stuff up here. There's a nil tube and an antigen tube and a mitogen tube. Xavier, what does this mean to us?
It's very important in this test to check that the positive control is effectively positive. It means that the lymphocytes of the patients are able to respond to a non-specific stimulation. And this non-specific stimulation is made with PHA. And you can see here for this patient, it is really positive because you have 22. It is considered as really positive. The negative control is negative. So the test is interpretable.
And I think that that's a point that, as we as rheumatologists, kind of advance on this learning curve, we understand how to interpret this type of test. So this is a negative test, but, I'm going to give you an alternate scenario. The same thing, I assume the group would say that this little slip of paper comes back and says, you're positive. It's not time to exactly pull the trigger. You want to actually see the data from the test. And I have another test here that shows us some data. Kevin, how would you interpret this again?
Well, it's quite positive. Their TB antigen is minus nil levels, 4.1 apparently. That's quite positive. And on the T-spot side, again, you have a pretty high number of cells. It's a little odd to see nils of 0. Usually there's some measurable interferon-gamma. This may be because she's immunosuppressed and at baseline she's making less
and stuff like that.
But as Xavier noted, the mitogen reactivities there, her lymphocytes are responding at least to PHA. And again, there may be some difference in your ability to respond to PHA than, say, ESAT6 or something, one of the other antigens. So I always think about that. But again, this is clearly a positive test. This would be enough for me.
Okay. Well, in real life, this patient had a test that was neither positive or negative. And it came back, and it was called indeterminate. And this is a phenomena that does occur and may occur in totally healthy people in a tiny fraction of patients. but data from Xavier's group and many others have suggested that as you get on immunosuppressive therapy and have active autoimmune and autoinflammatory diseases, the rate of this indeterminate reaction goes up. What does this mean when it's indeterminate, Xavier?
Indeterminate means that the T cells do not react sufficiently with a non-specific mitogen. So if there is no reaction of T cells to a non-specific mitogen, you cannot interpret the reaction of T cells to a specific antigen.
Because it's dependent upon the health and robustness of those cells to be able to respond to a stimulus.
So the hypothesis is that it may be related to immunosuppressive therapy, but in the large study we conducted in France in 400 patients tested with TST and with different IGRAs, we had 2.7% of indeterminate, and there was no clear relationships between the treatment of these patients.
Was the indeterminate reaction the same between the two available tests, the quantiferon and the T-spot?
In this study, it was less frequent with quantiferon than with T-spot TB. With T-spot TB, it is around between 5 and 6%. With quantiferon, it is between 2 and 3%.
All right, so we have this indeterminate test now. So how, Mr. TB, what do you do with this?
It's really just indeterminate.
Thank you for tuning in.
It doesn't help you. It's not positive, it's not negative. So you can't make any conclusion as to whether the person's positive or negative from being indeterminate.
Do you repeat this test?
I do. I generally do repeat it, yeah.
Okay. I mean,
I would repeat it after a period of time and maybe even after therapy. But I think it is, to me, in practice, it is the same as this is covering allergy when we used to do allergy testing, which means if someone's allergic, there still is the risk they could be positive and they could progress to active disease, which means monitor, watch, be suspicious. That's what you're supposed to do anyway on these therapies.
But one of the things I think that these tests are sort of new, and one of the things I think we've learned in rheumatology is when tests are new, we sort of think of them as being perfect. Like the ANCA was a perfect test for Wegener's. But the IGRA now, you see the indeterminate levels, and as I covered in my session, an issue that we don't know enough about is variability. Yeah. So, and there have been a couple of studies, mostly healthy people, healthcare workers, where you do serial testing, and the trouble with an indeterminate test is that it may be positive one time, indeterminate, then negative. It bounces around. And I think if you would send the same blood to the lab several days in a row, you may get different results. And if they're close to the threshold, it may appear as if they're becoming positive or becoming negative. So I think we still need to gain more experience with this test like we do with all our rheumatologic tests.
Maybe two short additional remarks. The indeterminate may also be due to the fact that the negative is not negative.
Yeah. Yeah.
So you have to check that, especially in patients without any immunosuppression, like ankylosing spondylitis patients. And the second short remark, in this situation, maybe it could be a good indication to repeat the test, but maybe to do the other IGRA. For example, if it was quantiferon, to do the T-spot TB, because maybe one may be indeterminate and the other may not be.
So we have some options. And let me just reduce this case to say that, based upon the epidemiologic weight from Peru, the borderline PPD, indeterminate test, repeat testing, this patient is diagnosed with latent tuberculosis. So you've outlined the therapeutic options for this. We're starting to treat for latent TB. Just quickly, how long would you wait to start this TNF inhibitor? Patients on going to do 9 months of INH.
I would give the INH and then I would give the TNF inhibitor 5 minutes later. Because the package insert from the FDA, which is a carefully studied and carefully worded language that based on interactions between the FDA and the CDC and many experts in the field say that you just need to be on treatment as you go forward, and be best to start treatment before you receive a TNF inhibitor. There is no need to, as some people believe, to wait 1 month, 2 months, receive a full course of therapy. That delays therapy, which I can only assume is needed if you're using a biologic.
Yeah, I would agree with Jack. The only data that really speaks, there's not much data that speaks to it. One study that does is the START study, where they did exactly that, where they started concomitantly, and that seemed to work perfectly fine. What I do in my practice is also to start them at the same time, but there's a built-in measure of safety or hesitance, if you will, because the INH will get filled that day, and they'll start taking it.
Take some time.
The biologic will take a pre-authorization and some negotiation, so you actually get a week or 2 or 3 weeks in between, which I feel useful in that now I'll see what the liver function tests are doing in this person before starting the other.
I actually, and I agree with exactly what you said, Jack. I feel that a week or 2 lead-in, see, they're going to tolerate these tests or they're going to throw them in the garbage can. I mean, there's some nuances, but data-driven, they could be started simultaneously.
I will have a little different attitude. I will treat the patients with INH plus rifampicin, a double therapy, and I would begin anti-TNF 3 weeks after the beginning of the treatment. It is a recommendation we have in France. And,
we wouldn't do that.
Yeah, but these recommendations are based to the fact that with the B therapy, you eradicate tuberculosis, the tuberculosis bacillus, much more quickly than with monotherapy. I don't know what Kevin thinks about that.
I mean, that's a perfectly acceptable strategy.
And we also have now the DOT 12-week regimen. So we have a lot of options.
I mean, I agree. I don't think you need to wait. I mean, the 1 month came from the Carmona paper, the Spanish experience. I do think in practicality it's nice to wait a week or 2 to make sure that they actually pick their INH up and are taking it. Sometimes people don't do that. And I think probably from a practical standpoint, that's usually what happens given the PAs necessary for
It is important that people know that that there isn't a downside from the standpoint of what will happen to the TB bug, meaning the supposition that you have to wait so the therapy can take hold is not well founded, and there certainly are very aggressive cases of TB and HIV positive individuals where they're using steroids concomitantly to treat the condition, or there are studies where they've actually used Enbrel or etanercept along with TB therapy, and they did not have worse outcomes, they had better outcomes. The idea being maybe the TNF inhibitor may cause breakdown of the granuloma, apoptosis of cells, better delivery of the bug to the drug, and get more effective killing and control of disease.
Okay, I got to cut this part of this discussion off. No, I got to move to 2 final points here. The chairman's prerogative. So you have this patient with latent TB, and they're going to treat him with some regimen. How does this influence your choice of TNF inhibitor? Jack, what would you select? Or does it make any difference to you?
It makes no difference to me at all, and it's whatever the patient desires based on administration, risks, whatever.
No difference. The discussion is as it would be just beginning any TNF, and it's driven more by the patient preference, including pharmacoeconomics.
Xavier.
I will select etanercept, not because this patient has latent TB, because she's going to be treated for this TB, so she can receive either the monoclonal antibody or the cellular receptor, but because she comes from Peru, and she's going to come back to Peru to see her family, so she is at risk of reinfection with TB. So it could influence my choice.
Kevin, you have strong feelings?
I think it's something to think about. I mean, I agree. I think if you take the LTBI off the table with therapy, that any of the TNF drugs should be similar in their safety profile. But this is an important point, and if they have ongoing risks, it's something to consider. The thing I need to add in there is chest radiograph, because the thing we did skip over is we went from screening test to saying LTBI, and we do need to emphasize, or I want to emphasize, that you still need that chest X-ray, make sure they have no active disease, and then you go down that LTBI treatment pathway.
I cut Kevin off prematurely, and his outstanding presentation clearly summarizes that, and implicit in stating that this is latent TB means that there's a immunologic memory to TB in some form, no signs or symptoms, and a negative chest X-ray.
Right.
So,
Yeah,
all right, am I
it's important to
back in
emphasize.
good
That's
graces?
it, absolutely.
All right. So finally, there are some guidelines. You talked about the CDC guidelines, which essentially have told us that IGRA and TST are interchangeable. And there are certain circumstances where it may be more favorable when you can't get somebody back to read it, et cetera, et cetera. The NICE guidelines from Europe have just been put out here very recently. And they are a little more explicit in recommending going straight to IGRA in certain circumstances. And explicitly stated in these guidelines are to go straight to IGRA in immunosuppressed patients, including possibly HIV. So I don't know, I'm not stating that this is categorical recommendations for all of us, but there are some trends out there going from we have a new test, we're trying to figure it out, to it's an interchangeable test, to some large health authorities actually demonstrating that, I think it brought out, if you listen to all of our presentations, if you tried to get FDA or EMEA approval for a TST today and it was the first thing that you're trying to do, I think it'd be pretty tough going. So any final comments here?
Well, I'd like to ask my colleagues if these tests perform equally well, TST and the IGRAs in low-risk populations. In high-risk populations, in the immunosuppressed, do you believe there is an advantage, as the NICE guidelines may suggest, of using the IGRA over the TST?
That's a good question, Jack. I think from a specificity standpoint, there's a clear advantage. So in places where France uses BCG, or you have historically, I mean, this would make sense. I think in places that don't have BCG and there's low-risk situations, I don't know. I think the question of relative sensitivity between the two tests is still an open question.
In my session, I cover a little bit about that, and I think that, yeah, you could make that argument that it would be better. And another interesting, I think, as we're talking about using the TST, and it's come up in several of the talks, it can be operator dependent, and you really want someone who's putting it on, who's very experienced. Well, the less we use it, is it going to be worse over time? So in 5 years, will you have to go get a very, very old nursing assistant to go get the PPD placed because no one else knows?
Reading the LE cells.
Exactly, because no one else knows how to do it. In that case, it'll actually, that will be the answer, because we'll fear the actual technical aspects of the test and we won't believe it.
Xavier?
I think that IGRA is not influenced by BCG and is less influenced than TST by steroids and immunosuppressive therapy. So in these two situations, previous BCG, high immunosuppressive therapy, I would prefer IGRA to TST.
I will close by merely saying, as a matter of fact, that at the Cleveland Clinic in our 30-man rheumatology group, we use IGRA tests exclusively, and also in our 41,000 employees in the Cleveland Clinic health system, we do IGRA as the routine test now for screening for TB, and it is found to be more cost-effective, more reproducible, accurate, and our record keeping is better. I think all the vagaries have been brought out by these guys in terms of the operating characteristics. There's still a lot of unknowns going here, but we are in a lot better position today to sort out the issue of whether patients have latent TB and what their risks are than we were merely a few years ago. So I want to encourage all of you out there to come back, if you haven't, and view each of these webcasts, which go into explicit areas of testing, the biology, the mechanisms of actions of some of these drugs, and also come back to the R.J. Fasenmyer Center for Clinical Immunology CME site. We have over 100 programs online right now. Most of you out there are frequent visitors, so come on back.